For case 3, we have a 23-year-old female with no comorbidities. The patient has a history of 2-year history of dysphagia. Dysphagia and weight loss. The labs show a hemoglobin of 13.1. The patient has an Eckert score of 9. The endoscopy done in June 2021 showed a dilated esophagus with retained fluid and spastic cardia. Okay, thank you. Next slide, please. Next slide, please. The barium swallow showed a smooth tapering in bird's peak. The manometry showed a, this is the conclusion of it, which showed type 2 achalasia. The decision for today, we're going to do, for the type 2 achalasia, we're going to do the POEM procedure. And thank you. We'll go to room 2.
Morning.
Yalla Sherbini.
Hello. Good morning.
Yes.
Yeah, you can hear me?
Yes,
Yeah, this
I can hear you.
Yeah. How are you, everyone? Welcome in Egypt, here from Cairo. I think it's 9 a.m. here. Our case, as you hear by Dr. Amira, is female patient with type 2 achalasia. We clean the esophagus and we assess the cardia. As you see, we are going downside, so this tight. Then release after that.
Have the endoscopy.
You don't have the
image.
Okay.
Yeah.
We need the endoscopy
We
image.
need the image of the endoscope, please.
So hello everyone. Good morning. This is Shaimaa from Egypt. I think Dr. Cesare, we have met before. This is yes. This is our team from Cairo University. As you all know, Cairo is the capital of Egypt. And our team, me, I am Shaimaa ElKholy, Dr. Mohammad ElSherbiny, and Dr. Kareem Essam. We are the team of third space endoscopy in Cairo University. We have started our third space endoscopy program in 2018. After getting training in China, in Shanghai, with Professor Bing Hong Zhou in Zhongshan Hospital, Fudan University. And we owe them a lot. We started our program, our first case in 2018, and now we have exceeded 250 cases of third space endoscopy. For POEM exactly, we have 191 cases of POEM right now. All of them are, we have a very high technical success rate and clinical success rate. You can see now the endoscopic view.
Yes. Could you please to give the idea the position of the patient, how you see the patient?
Yes, this is a
posterior.
yes, this is a young patient, 23 years old. The patient is under general anesthesia. She is in the supine position. And we are using a Fuji scope, okay, and we are using ROEYA VAR 3. If we can show the camera shows our setting. Okay. This is the VAR 3. We now use EndoCut Q for cutting, and we use the precise sect. Actually, the precise sect is a new mode from ROEYA, from which we use in dissection, because we believe that the precise sect has a less carbonization. It doesn't cause like blackening of the lumen like the forced coag, so we can use the precise sect. So Dr. Mohammed now is using the EndoCut Q, and we can use the precise sect in dissection.
Can we increase the effect of precise sect?
Sorry?
إبرام ممكن تزود.
This is the anterior or posterior approach.
Sorry.
This is the anterior or posterior.
I'm sorry, I don't understand. I don't get the question.
Which route you have closed, anterior or posterior?
This patient is a naive patient. This is her first time. 4. خلي 4 ونص.
What's the
As-
solution
yeah,
to inject?
We use methylene blue, as you can see here. ممكن الكاميرا معلش. We use here methylene blue, as you can see here. It is connected to the, yes, it is methylene blue, and it is connected to the Erbijet, as you can see here. And here's the Vi3. Here's the Vi3. You can see our settings.
Yeah.
This is endocut Q33, and the precise sect we increase to 4.5.
Now we can dissect in the tunnel using
هو
precise
السؤال كده؟
sect with the effect 4.5
Okay.
as you can
Posterior.
see.
Yeah.
So we usually do the posterior approach, which is at 5 o'clock, just to the right of the spinal cord.
What the length of the esophagus cut? How? What the length that you cut on the esophageal and gastric part?
الصورة تقصر شوية بس عشان على الميت.
مش سامعة.
Excuse me, your question again?
What the length that you cut on the esophageal side and gastric side?
Yes.
We assessed the cardia. It was at 40 centimeter from dental arch. We started 10 centimeter before. This is a type 2 achalasia. Usually we assess the length of the myotomy or the tunnel by revising the endoscopic imaging and see the upper ring we can see, and we start just before it. In this patient we started
mucosa فوق.
we started by ideal length is 10
اخرج برا ولا-
centimeter here, as you see. This posterior
Yes.
approach, as Dr. Shaimaa said. This our incision, and this the plane we will go in towards the cardia. We'll go inside the tunnel again.
So after creating the tunnel opening, we go inside and then create the tunnel. We go on with the submucosal dissection till 2 to 3 centimeters below the cardia. We are now doing dissection using hybrid knife, where we can cut, coagulate, and inject in the same time. As you can see, Dr. Mohammed is switching the scope. Here's the muscle at 6 o'clock. This is the muscle here at 6 o'clock, and this is the submucosa, and above we have the mucosa. And we usually dissect close to the muscle because we are going to cut the muscle later on.
What is the device you use now?
We use a hybrid knife from Irby, and we use the Vi3. We use the Vi3 from Irby.
No, I asked about
The scope, the needle, we use a hybrid knife.
a hybrid.
Yes, the hybrid knife. Here's the hybrid knife, as you can see here. This is the hybrid knife that has 2 connections. The first connection is connected to the Irby device, and the second connection is connected to the jet. So we have this Irby jet tower that connects to the hybrid knife, so we can cut, coagulate, and inject at the same time. And actually we have, if you look down here at the foot of Dr. Mohammed, we can see that he has 4 pedals. 4 pedals. هات البدلات بعد إذنك. We have 4 pedals. The first one, the gray one, is for injection. Okay. The first one is for injection, and the second one is for coagulation, and the yellow one. ممكن تخرج معلش شربيني ثانية شربيني ثانية. Okay, so we have here, this is the classic settings. باينين يا شيل رجلك يا شربيني. Okay, so we have here 4 pedals. Okay,
how we know we list ET junction? How we know to list ET junction?
Yes, this is a very, very nice question. I will ask Dr. Amira to show us a presentation. On the presentation that we published a paper in the GIE. Our team published the paper in GIT just last year about the methods of how to detect the GE junction from the tunnel side. So this is a very good question. The first is that we measure the length of the scope. So our cardia was at 40 centimeter before we start, so we know that we exceeded 4 centimeter. This is our paper, as you can see here in the GIE. It's just published 2020. The four classic steps. The first one is we measure the first one. Dr. Amira, please. The first step is to measure the length of the scope. The second one is as we approach the cardia, we can see the palisade vessels. And then the third step, that we can see that we have after just a release after narrowing, which is very, very significant for the cardia. The fourth one is that we can go outside the tunnel and we revert into the stomach and we can see the blue sign. Okay? And the fifth method that we published in the GIE is that we use the double scope trans-elimination method. We used an ultra-slim gastroscope. This ultra-slim gastroscope, we just put outside the tunnel and we retroflexed it so we can see the light of the first scope in the tunnel. These are the common methods. The four methods are the most common methods that we see the cardia. How can you identify the cardia from the tunnel side? And here's the double scope trans-elimination method. And actually, we are performing a study in Cairo University about using the fluoroscopy to identify the cardia. But actually, we prefer to use the fluoroscopy in cases of difficult and sigmoid esophagus, where we usually get lost. So before we start, we just put a metal mark on the cardia from outside the patient before we start, so it can help us not to get lost in the tunnel. So
That's good technique. Eh?
Sorry?
Ask you, what about the complication? What you tell me about the complications in
Yes, actually, thank you. This is a very nice question. Actually, the most common complication that we have, we don't consider this as a complication, we consider it as a sequel, is the pneumoperitoneum. We usually have that air inside the abdomen of the patient that we can successfully evacuate during the procedure with underwater seal. The second complication that can happen to us, that we have sometimes we have aspiration pneumonia. You know, usually the patient with achalasia, they always have bad chests because they have like sort of frequent aspiration. We have also cases of pneumothorax. We have 2 cases of tension pneumothorax that we could evacuate them during the procedure. And we have case of DVT. You have a DVT and pulmonary embolism. And we had 1 case of esophageal leak. It was a late leak, like 8 days post the procedure, and we were successfully able to control the leak by putting a stent, but actually the patient was stayed at the hospital like for 3 weeks and he got COVID and died. This is our complication rate. We have also 2 cases of repoem. We have 2 cases of repoem, but the repoem was outside, the first poem was outside Egypt, and we did it here in Egypt for the repoem. As you can see here now in the tunnel, Dr. Mohammed is approaching the cardia. It's now getting tight. It's now getting tight. And Dr. Mohammed will show us how to control the bleeding with the hybrid knife. You can see here, there is a bleeding coming out. So we inject. And then we coagulate. The injection with the jet helps us a lot because it makes it away from the mucosa, because coagulation near the mucosa can lead to delayed perforation or delayed leaks. So we usually perform dissection, coagulation, cutting very close to the muscle. It's okay if we just cause like a superficial injury to the muscle. This also helps us to guide where's the muscle, where's the mucosa, and how we go through the tunnel. Now he's getting down to the cardia, and you can see the palisade vessels is starting to appear. Can you show us the palisade vessels here? Freeze. As you can see here.
Yes.
So we have now reached the upper limit of cardia, and the cardia of this patient is 2.3 centimeter as measured by the high resolution manometry. So we have to go. He's now just getting out of the tunnel because the patient is her stomach is inflated, so we deflate the stomach. One of the most important things that during endoscopy we have to check for two things. It is the peak pressure of the patient, just to have the notice if we have any air under tension, like pneumoperitoneum, like air intragastric, or just pneumothorax. So the first thing that we look at the anesthesia is the peak pressure. The second is that we measure the CO2 using the capnogram to keep our CO2 within the normal level. So we communicate with our anesthesia doctors so that we have also to revise the peak pressure and the CO2 or the capnogram to measure the CO2 during the procedure. Now it's starting that we're having this blue sign on retroflexion, but actually this is not satisfactory. We have to go more deep below the cardia. Here, as you can see, here's the blue color appeared on retroflexion. And then we go outside. The cardia starts to relax. Even with the submucosal dissection, the cardia starts to relax. And then we go inside again the tunnel. We assess our tunnel. This is very nice. Now it's about to fall into the stomach because we found it in that constriction, the tight lumen, and then we fall into the wide lumen of the stomach. So we have a multicenter study, Dr. Amira. We have a multicenter study that had performed. This was the first multicenter study to be performed from the Arab region or the MENA region. This is our team. No, the center study. It was performed from 3 Arabic countries, from Saudi Arabia, from Kuwait, from Egypt, and actually it has this study had a very the technical success was 100%, and the clinical success was like about 95.5%, with a very significant drop in the Eckert score. This is our first study from the MENA region. And you can see this is our team in Cairo University. As you can see, Dr. Mohammed was the first one to perform POEM in Egypt in February 2018, and now we had reached 190 cases. And we have done a lot of cases. We have done naive patients. We have done patients with post-Heller myotomy. We have done patient post-dilation. And also we have done 2 cases of free POEM. And interestingly, we have done a case of post-sleeve gastrectomy.
I asked you how many is the percent recurrent?
How
How
many?
many is the percent recurrent?
The
Percent recurrent.
of recurrence, yes. Yes, we have yes, the percent of recurrence was for in our cases was just it was not about recurrence. It's about that we assess the clinical success with the Eckert score. If we reach the Eckert score of 3 or below, we consider this is a clinical success. However, we have 2 cases where we have Eckert score more than 4, but actually those cases they have a significant drop in the IRP and the LES pressure, and they are much satisfied. So our recurrence rate is about 2%, and even worldwide it's almost the same.
Yeah, that's right. As we know, for the young patients with achalasia, the recurrence rate is relatively higher. So even for the patients who received surgical myotomy, so for each patient is very young. So what's your policy to prevent recurrence?
Okay, to prevent recurrence, we usually depend mainly on the high resolution manometry, because in the high resolution manometry we measure the length of the cardia. Maybe we believe that one of the causes of the recurrence is that we don't go deep inside, because the cardia itself is 2 centimeter, and we have to go down by the cardia by another 1 or 2 centimeter. So this is one of the measures that we assess, and we follow up our patients regularly, so to assess if it's really a true recurrence or just sometimes you get, like in type 1 achalasia, that the patient had the dilated esophagus. So the problem is not that the cardia is tight. Once more, the problem is that the patient cannot, he doesn't have peristalsis. So it looks like recurrence, but actually it's not. So in this case, we repeat high resolution manometry and we assess the IRP. If the IRP is normal, so there is nothing we can do for the patient as long as his esophageal muscles are not working anymore.
How many percent of the lymph in your series? How many percent lymph disease?
How many percent of what?
Lymph esophagitis.
Yes, this is a very, very nice question that I like to ask. Actually, one of the major drawbacks of POEM is the gastroesophageal reflux disease. For our studies or for our patients, we have 30% of gastroesophageal reflux, and from this 30%, we have 20% asymptomatic. They don't have any symptoms. We just observed the reflux during the follow-up endoscopy, and only 10% of them was asymptomatic. So we are now going to shift to another room with Dr. Mustafa, and we will come back again.
Hello?
You come back.
Yeah. You hear me now?
Yes.
Now we finished our procedure and we go outside the tunnel and we went through the cardia to the stomach to assess many things. To insufflate the air, okay, from the stomach, and to assess the opening of the cardia, or after myotomy, to assess it. As you can see here, you can see the cardia is widely open. Okay. After that, we assess for any mucosal injury after finishing myotomy. Now we will go again inside the tunnel. This is the mucosal entry or the tunnel opening. We start our myotomy just 2 centimeters below the mucosal entry. We start first with, as you see, with selective myotomy. We preserve the longitudinal layer, and we did myotomy for the circular layer for a short distance. After that, we complete full thickness myotomy. As you see here, this is the edges of the myotomy. We go towards the cardia. This is the cardia. As Dr. Shaimaa said before. This is a palisade vessel. And we went for 2 centimeters below the cardia. The cardia of this patient, as mentioned before, is short. This is the end of tunnel. Here is myotomy. We will check again. We wait for 10 minutes after finishing our procedure, and we try to elevate her blood pressure and check for any bleeder. We check for hemostasis at both edges of the myotomy, right and left. We check again. If you are worried about any vessel, this is the vessel we coagulate before. This one. This is the mucosal side, and this is the muscle side. We check many times. We check if there is any bleeding need hemostasis. Now it's okay. No need for hemostasis. This is the longitudinal layer. After that, we will go outside. We'll check the cardia again. Now we can go inside without insufflation of air. Now it's widely open. We go inside the stomach and insufflate air. Okay, then we will go back and we'll close the tunnel.
So POEM is usually nice and easy in naive young patients. No major bleeding, no fibrosis. And we thank Dr. Mohammad for this very nice case. And we are starting with the clips. Dr. Kareem will explain to us the clips we are using.
Hello everybody. We are using now clips from Boston Scientific.
My last question is what you recommend for the center to start this procedure? What your recommendation?
What's our recommendation?
Sorry?
Yeah, to start training.
So,
Training, yeah.
yeah, would you repeat again your question, please?
What your recommendation the center who want to start poem.
Yes.
Yes, actually there is an ECGE there is usually guidelines for everything, but maybe in the poem we start first with observation. We have to start with observation, observing the technique, and then afterwards we start on like we did. We start on we had a cooperation in Cairo University with China, so they came like starting from 2010 to do poem in our center in front of us for patient life cases and endoscopy workshop. And afterwards we went to China to have hands-on training on animals for poem for 3 weeks. And then afterwards, after 1 year again, all of us, the 3 of us, we went there for China. We observed many cases. They do like about 500 cases per day. We started with the observation. And then after we start with the observation, we start in the training in the retrograde fashion. The first we start to learn is how to close the tunnel.
Yeah.
Then afterwards the myotomy. Then afterwards the dissection. And then afterwards the tunnel injury, which we consider the most important step.
So Dr. Muhammad now put the first clips. This is the most important one. Usually we close the hemoclips from distal to proximal. The most important one is the first one, which is the most distal, which approximate the edges of the mucosal opening. It is important to put the clips at the close distance to each others, not to make a big distance between the first and second clips to avoid post-operative leakage. The advantage of the clips is it is rotatable. We can rotate. The assistant can rotate the clips. Also, it can be reopened again. If the position is not satisfactory, we can open it again to reposition the clips.
So regarding the question of the center who wants to start third space endoscopy, we have to have proper settings. We have to have high definition scopes. We have smart electrosurgical machines. We have to have the CO2 insufflation, water pump, ventilator, everything that is needed for closing perforations and bleeding. And of course we have to have a backup surgeon. And now we are almost finishing our procedure. It's almost maybe 2 clips remaining.
We will shift to another room. Okay.
I think the time is up. Thank you very much for the